So this is my conflict of interest, the Atlas for Ultrasound, and I'm an education consultant for Philips. In 2006, we started this small special interest group through the ASRA and ESRA, and feel free to find us on the website for the American Society of Regional Anesthesia and join if you're interested. The case. Unfortunately, I'm this old guy, and everyone else in the pain field, smart guys, of course, they are this young man. So that's why if I want to promote for ultrasound, usually to convince someone, if it's the first time to get introduced to ultrasound, would be something like intercostal block, peripheral nerve block like lateral femoral cutaneous, or stellate ganglion block. And I think by the end of the presentation, you should get a sense why I really like to use ultrasound in the neck injection in general, specifically for cervical sympathetic blocks. Why in the neck? Because I truly believe that ultrasound is very, very helpful in soft tissue structure, to see soft tissue structure, and bone surface. That's why the neck will be an ideal place for this. Lots of arteries and nerves and esophagus, soft tissue, very compacted in a very tight area that we put the needle to do the block in. So it might be safer in the neck area. So in the literature now you can see description for all the techniques in the neck, but I think the last one is the most important one. Just a quick, I promised we'll review the anatomy, Sonoanatomy before the block quickly. So the basic idea for the cervical spine, any cervical spine injection, is to really identify the level. So for procedure that the patient is supine or lateral, for stellate or cervical nerve root if you want to do it, or cervical facet, we count from lower up, C7 and C6. How? By looking at the transverse process. You can reconfirm by the vertebral artery, but putting in mind that in 10-12% of the patient, vertebral artery can be still anterior at C6 or C5. If the patient is prone, like for occipital or sitting, like for occipital nerve block or upper joint injection, you have to count from up down. Occipit C1, C2, and Bernard showed very delicately. So C7, you have no anterior tubercle, only posterior tubercle. This is in contradiction to C6, very sharp anterior tubercle. I think this is the most important landmark. You cannot miss the sharp anterior tubercle of C6, especially in males. In females, it's less prominent, but you still can differentiate it. So this is a typical C7. This is medial or anterior, and this is lateral or posterior. No bony structure here. Vertebral artery is exposed, the nerve root, and the sharp transverse process with one tubercle. So it's the transverse process, it's a posterior tubercle, no anterior tubercle. This is different. When you start to scan up, you will see this coming in the picture. Usually it's not in the same area, anterior a little bit, and we'll show it in the workshop. You cannot miss this sharp anterior tubercle. So this is median lateral. This is the posterior tubercle. All this is transverse process. This is the nerve root. And you cannot see the vertebral artery because it's hidden inside the transverse process. So with the acoustic shadow, you cannot see it. When you start to go higher and higher, the anterior tubercle start to be the same like posterior tubercle. So it's like a hand or a cup holding the nerve root in the middle. And the same for C4 and C3. So just to tell you, this is C7, vertebral artery, and then follow this. You're going to see a sharp anterior tubercle. There is a vertebral artery here now. You go higher, you start to see the C5. So we'll let it run one more time. Vertebral artery, C7 nerve root, posterior tubercle. We'll go higher. Vertebral artery will go inside the transverse process of C6. So now we identified the C6, C7. This is what I'm saying. If you follow only the vertebral artery, you might be misled in 10%, 12% of patients because it can be anterior to the sharp anterior tubercle of C6. When the patient is prone, even in big patients, you still can be able to see the bony surfaces. This is like few centimeters of fat here. So this is the occiput, no spinous process, C1. This is the largest window between C1 and C2, so you can see through. Spinous process of C2, C3, and C4. The same occiput, C1, C2. If the patient prone but short axis, then you start to see the occiput, and then the first spinous process, very rudimentary spinous process, this is C1. You cannot miss the first pivot spinous process of C2. So this is a quick review of the sonoanatomy from anterior and from the back to differentiate the level. Cervical sympathetic block or stellate ganglia block. Again, we used to do it blindly years ago, and the idea is to feel the carotid pulsation, push the carotid artery laterally, and put your finger in between the trachea and the carotid artery to create a room for you, and put the needle and advance it till you touch the bone, and then you pull it a few millimeters so in order not to inject in the muscle, and just inject anterior to the muscle. And you inject a big volume to make sure that we are covering the sympathetic area or the whole area. The point that it's blind, so you can easily get in and out of the carotid artery, or if you miss the bone or in between two vertebrae, you will be in the vertebral artery. The idea that I am doing the block higher than C7 because I'm trying to be safe to avoid the vertebral artery is not really true, because in 10-12% of the patient, vertebral artery is anterior to C6. In all the patient, the vertebral artery is exposed between level and the other. So even if you are higher than C6, if you are not on the bone, you can injure it. So we changed it a little bit, and we said, how about if we do it with contrast, which is a little bit a step forward. Why? Because we can easily count. This is the first rep, T1, C7, C6. So I'm at C6. At least when I inject the contrast, I roll out intravascular injection. The tip is not intravascular, but I'm not sure if the needle already went in and out of an artery. And we didn't have any studies or any randomized controlled trials to say fluoro is safer than blind technique. But we take it. Why? Because it's common sense. This is the same when I'm trying to advocate to use ultrasound. If we can see all those structures here, we can plan for a safe path for the needle. So we'll give credit to Steven Capral from Austria, the first one who reported this really years ago. And then no one was really into ultrasound till in the middle of a few years ago, start to revive the dying art and try to learn and teach ourselves how to do those blocks. So by seeing all the soft tissue structures, we can avoid arteries, can avoid the esophagus, especially on the left, can avoid injecting or injuring nerve roots or neurostructures. The more important that we do a good block, precise block, specific block, very selective block. We do these blocks mainly as a diagnostic test to rule out sympathetically mediated or maintained pain, CRPS. So I want to make sure when I'm numbing something, I'm numbing the sympathetic chain. So we can monitor the spread of the local anesthetic, and we can avoid most of the complication. Esophagus, first one. With the traditional anterior paratracheal approach, you can injure the esophagus, especially on the left side. On the right side, really, it's very difficult to have the esophagus. It's more shifted to the other side. So to orient you, this is midline, and this is lateral, the skin here, and this is the trachea. Air and bone are your enemies in ultrasound. You cannot see deep to air or bone. This is the anterior surface of the vertebra. And this pouch is the esophagus. You ask the patient to swallow, you see the contraction in the muscular wall of the esophagus, and air bubbles or food or lunch inside the esophagus. This is normal esophagus. Go more laterally, you see the carotid artery, the vein is compressed, and this is the longus coeli and the vertebral artery. So this is C6 or below. I'm not sure it's C7 or even T1. The idea is we keep scanning cephalate till we see the C6. In patient with diverticulum of the esophagus, you can easily go in and out of the esophagus with fluoro, unless we ask the patient to swallow barium like this. We don't do this. So on the left side, the esophagus is really vulnerable to injury. This is just last couple of weeks, just published by Urs Eichenberger and his group. It validated what we are saying. It makes the common sense into objective data for the reader. So they scanned volunteers and see how many vital structures that one avoid are in the path of the needle. So the esophagus was on the left in 1 out of 3 cases. On the right, there is no esophagus. 1 out of 3 cases without dislocation. They use the transducer as a mean of your finger to try to avoid or dislocate the carotid artery of the esophagus. It didn't work, so still you can injure it. Vertebral artery is exposed at the level of C6. This is at C6. In 10% on the left or just 3% on the right. There is other arteries, and this is more important. 20%, 1 out of 5 patients. 1 out of 5 patients. There was an artery or a vessel. We don't care about what's the name of this artery. Is it the ascending cervical, internal thyroid, thyrocervical trunk? It's an artery that you could injure while doing this procedure. It's an eye-opener and an alarming. Thyroid, you go in and out of the thyroid all the time. This leads to my concern. I mean, in radiology, when they do a fine needle biopsy of the thyroid, they use 12 or 14 gauge needle. So it's not a big deal if you're using a 25 gauge needle. So this is the anatomy. This is the picture that we want to put in our minds whenever we do this block. Medial and lateral. Trachea should be here, and then the thyroid, carotid sheath, carotid artery, and the vein is compressed. This is a sharp anterior tubercle of C6, small posterior tubercle, the nerve root in between. So this is C6, longus colli muscle, and at C6 you start to see the origin or the insertion of the longus capitis muscle whenever you look at it. In the groove between those two muscles, usually this is the most reliable anatomy for the sympathetic chain. Sympathetic chain runs here. At this level, at C6 level, this will be the middle cervical ganglion. That's why usually I tend to say cervical sympathetic block rather than stellate ganglion block. Stellate ganglion block in the thorax, in front of the neck of T1 rib. So it's just we're counting that if we inject it in the correct facial plane, the medication will go up and down along the longus colli muscle as far down to T3 and T4 even, if you're in the correct facial plane. And this is an advantage of ultrasound. So this is what I'm saying, that we need to be very specific. With just gentle compression of the transducer, you compress the vein. We all know that the vagus nerve is in the carotid sheath, in between the big artery and the big vein. And this is your sympathetic chain. So you are literally two facial planes or two facial layers between it, 1 or 2 millimeters between the sympathetic chain and the vagus nerve. That's why it's very important. Because all what we do when we inject 10 cc's, you are numbing the sympathetic, you are numbing the vagal nerve, you are numbing C6 nerve root. So when you check on the patient in the recovery room, patient has no pain. It's because you did a brachial plexus block. The patient is numb. It's a somatic block. It's not a sympathetic block. We have the patient no efficacy, or you don't have increase in temperature. You did two conflicting things. You numb the sympathetic and the parasympathetic. Patient had recurrent laryngeal nerve, especially on the left, because you're numb the vagus nerve itself. Recurrent laryngeal nerve will be here, in the groove between the thyroid, trachea, and the esophagus. It's like an inch away. That's why we put the needle just to be exactly in this plane. When you inject the medicine, you want to make sure the medication is going just here, pushing the carotid sheath up. It's not in the carotid sheath or around the carotid sheath. So to monitor the spread of the local anesthetic, just under the fascia covering the muscle. It's not in the fascia cover or making the carotid sheath. There is too many layers. We're not going to get into sophisticated anatomy, but the deep cervical fascial layer, making 2 layers around the carotid sheath, then another layer here, and then there is a fascia investing the muscle. You want to be between the deep layer of the deep cervical fascia and the fascia investing the muscle. When you inject, it should look something around the muscle. If you have to inject in the muscle, it's okay, but you might need to inject a bigger volume, so the medication will go up and down. How I make sure? Sometimes, especially in the early training phase, I go with a long axis plan. So this is the vertebral bodies, discs in between them, long axis, the longus colli muscle, and you can see the medication. And this is the clavicle stopping me, going down even inside the chest cavity. We want to avoid this. This is a myogram. This is a contrast inside the muscle. We want to avoid this also. If the needle tip in the muscle and you pulled it more than 1 millimeter, you are in the carotid sheath. This is carotid sheath, contrast in the carotid sheath. Blood vessels. I think this is more important because this is where complication happens. Although the risk of fatal hematoma causing airway compromise is very rare, 1 in 100,000. It's fatal. That's why it's a high risk. And it's very difficult to design a study to prove that ultrasound is safer. You're looking for a complication or a fatality of 1 in 100,000. So you want to recruit 2 million in each arm to come up with a RCT trial showing safety. That's why we use surrogate. Yeah, I can avoid the carotid artery, vertebral artery, the esophagus, and this, again, common sense. However, Capral, when he did his report in 1995, he did the block with ultrasound, and then he repeated in a week later. He did the block blindly and checked in the patient in the recovery room with ultrasound. And when he repeated it with ultrasound. When he checked those patients in the recovery room, he said he found hematoma in 3 out of the 12 patients. It's really high. I think it's with the early learning curve. At least they were asymptomatic. Maybe you are inducing lots of asymptomatic hematoma that they don't cause a problem, which is okay. If you injected and you created hematoma in the thyroid gland, it's fine. Thyroid gland has a very tough capsule. It's not going to do anything harm. My guess that he was looking at the local anesthetic that he injected, because 3 hematomas out of 12 is really, we don't see it clinically at all. So what are the vessels that we can injure? Middle cervical artery and vein. They're usually inside the thyroid. If bleeding here, again, it will be contained in the thyroid. I'm not concerned much. This is our concern. The branches of the first segment of the subclavian artery. First one, the vertebral artery, thyrocervical trunk, and the branch of it is the inferior thyroid, which will give a big one, go up, which is the ascending cervical. Exactly, we are putting our needle in this area. So imagine there are too many vascular structures we want to avoid. The inferior thyroid artery, I always look for it to avoid it, because you can easily miss it. So I search for it first to see if it's at C6 level, at C7 level, and then just skip it, scan it up or down to avoid it. So this is C7 because the vertebral vessels are exposed. This is medial and lateral. And actually, the inferior thyroid artery starts from the subclavian artery, the first branch of the vertebral artery, then the thyrocervical trunk, and goes between the carotid artery and the longus colli muscle, curves. This is actually the same artery. This is the same artery and all of this artery to go to the inferior pole of the thyroid. So if you put your needle medial to the carotid or lateral to the carotid with fluoro, the needle can go through the artery and your tip is here, and you inject contrast by live contrast or live fluoroscopy, and you're fine, but you're already in and out of the artery. If you're using 25 gauge and you're slick one time, I don't think it's going to be a problem. But the issue that with fluoro, we want to hit the bone. So how about if you go in the disc between them, you pull the needle and go again. And I think this is where problem happened, that you are having too many attempts. It's a serpentine or a snake artery. It's very tortuous, so sometimes you have just small round structures. You can tell this is a different transducer. A finger transducer gives you a better anatomy. Medial and lateral. This is the esophagus, thyroid, longus colli muscle, vertebral artery, and the carotid sheath, and a couple of vessels here. So if you're still doing the this block, at least blindly, you have to remember this video clip, very important. This is medial and this is lateral, thyroid gland, the anterior surface of C7, longus colli muscle, carotid artery, the inferior thyroid artery, and the vertebral arteries. Too many vessels in the area. Whenever you have any rounded black structure, don't take it for granted that these are nerves, these are the brachial plexus, because usually they are not. You have to add color Doppler. You can see that these are actually vessels, and these are just a cross-section here. Some vessels, I don't want to name them, I don't care. They are vessels, I want to avoid them. Here I'm trying to follow this inferior thyroid artery here, and then it will combine with the ascending cervical and then join the subclavian artery. But there is no need to do it. It's just because sometimes with the small vessels, even if you try to add a Doppler, you don't see flow. The best thing is to follow this structure. Is it a lymph node? The lymph node will look black like this. Or no. So when you follow the structure, you learn by anatomy that no, it turns to be the nerve, no, it's an artery. This one, you can follow it all the way to the origin of the subclavian artery. Actually, the identification of the vessel in the neck was the thesis for the PhD. So how we do it? We'll finish in 1 minute. How we do it? Out of plane and in plane approach. Out of plane. You can see the needle tip here. I was touching the anterior tubercle. I just moved a little bit between the anterior tubercle and below the carotid sheath. This is the longus colli muscle. We start to inject. This is my injectate. Push the carotid sheath up. In plane, the needle coming in plane, you can see the whole shaft and the tip of the needle. Actually, my needle was inside the muscle. I pulled it a little bit. I start to inject here. Again, I'm pushing the carotid sheath. This is exactly the fluid I injected. And this is Michael Goffield's favor. It's to come as a lateral and come in plane. Sometimes I do it in plane. I prefer out of plane. It's easier and fast, but you have to know where is the tip of the needle. If you're not sure, I use hydrodissection. While numbing the skin, I advance the needle with hydrodissection so you can see where is it.